Hello, everyone, and welcome to this lecture on inflammation and dysfunctional wound healing. This is Chapter 9, and we'll be diving into the body's response to injury and how it repairs itself. Let's get started. So, what exactly is inflammation? It's the body's protective and coordinated response to injury or infection. Think of it as a multi-stage process aimed at walling off the injured area, preventing the spread of damage, and bringing in the body's defenses. It can be local or systemic, acute or chronic, and is usually proportional to the extent of the injury. Inflammation is a complex process involving vascular, cellular, and systemic changes. These changes can lead to discomfort, organ dysfunction, and a diminished quality of life for the patient. Understanding these stages is crucial for effective nursing care. Now, let's talk about acute conditions. These are characterized by a rapid onset and short duration, where the body attempts to eliminate the offender. Common causes include infections, injuries, surgery, and exposure to toxins. Recognizing these triggers is key to managing acute inflammation. In the first stage of acute inflammation, we see vascular changes. Histamine and bradykinin are released, causing vessel dilation and increased permeability. This leaky effect allows fluid and cells to reach the site of injury. This slide illustrates vascular permeability. Notice how the capillary pores open as the blood vessel dilates, allowing WBCs and platelets to move through to the injured area. This is a critical step in the inflammatory response. The extra fluid resulting from vascular permeability has several effects. It dilutes toxins, lowers pH, and contains WBCs that get to work. The byproduct of this battle can be purulent, exudate, or transudate, depending on the severity and nature of the inflammation. Vascular permeability leads to the classic signs of inflammation: redness, swelling, warmth, pain, and loss of function. These are all indicators that the body is actively responding to an injury or infection. This slide illustrates cellular chemotaxis, a crucial part of the acute inflammatory response. Immune cells like monocytes, macrophages, and neutrophils migrate towards the site of tissue injury, guided by chemical signals. This process involves integrins, platelets, and cytokines. Chemotaxis is the directed migration of cells in response to a chemical stimulus. Leukocytosis refers to an elevated WBC count, typically above 10,000 cells mmol, indicating an active immune response. Margination is the process where WBCs adhere to the endothelium and squeeze through the capillary pores. Inflammation mediators, particularly cytokines, play a vital role in regulating the inflammatory response. Released by WBCs, they can amplify or suppress inflammation, exerting both local and systemic effects. Tumor necrosis factor alpha and interleukin are among the most common. Acute phase proteins are another important component of the inflammatory response. Cytokines stimulate the liver to release these proteins, such as C-reactive protein, CRP, which marks material for phagocytosis, and fibrinogen, which contributes to rouleau formation and an elevated ESR. This flowchart provides a comprehensive overview of the mediators involved in acute inflammation. It highlights the interplay between plasma-derived and cell-derived mediators, showcasing the complexity of the inflammatory process. UBC differentiation is essential for understanding the immune response. Granulocytes like neutrophils, basophils, and eosinophils, and the granulocytes like monocytes and lymphocytes each play a specific role in fighting infection and promoting healing. Chemotaxis involves a dynamic shift in WBC types over time. Neutrophils are typically the first responders within 24 hours, followed by a transition to monocytes and macrophages in the subsequent 24 to 48 hours. These cells release inflammatory mediators that can either amplify or suppress the response. Neutrophils are the acute responders, characterized by their short lifespan and multi-segmented nuclei. In cases of severe infection, the bone marrow may release immature neutrophils called bands, leading to a left shift in the WBC count. They immediately begin phagocytosis of foreign matter. Phagocytosis is the process by which phagocytes engulf and digest bacteria or other foreign particles. This involves the formation of a phagosome, fusion with lysosomes to create a phagolysosome, and ultimately the killing and digestion of the engulfed material. Systemic responses to inflammation manifest in various symptoms, including fever, pain, lymphadenopathy, anorexia, sleepiness, lethargy, anemia, and weight loss. These symptoms reflect the body's overall reaction to the inflammatory process. Fever develops through a cascade of events. Microorganisms stimulate WBCs, which then secrete inflammatory mediators like interleukins and prostaglandins. These mediators affect the hypothalamus, resetting the body's temperature to a higher level. Lymphadenopathy refers to the enlargement of lymph nodes where lymphocytes mature. These nodes play a crucial role in filtering pathogens and mounting an immune response. Histamine, produced by basophils, platelets, and mast cells, has systemic effects, including vasodilation and increased vascular permeability. It's stimulated by physical injury, immune reactions, cytokines, and inflammatory mediators, leading to localized symptoms like sneezing and rhinorrhea. Prostaglandins and leukotrienes are potent inflammatory mediators. Prostaglandins are produced via the cyclooxygenase pathways, while leukotrienes are produced via the lipoxygenase pathway, each contributing to different aspects of the inflammatory response. This diagram illustrates the complex pathways involved in the production of prostaglandins and leukotrienes. Understanding these pathways is crucial for understanding the mechanisms of action of anti-inflammatory drugs. TNF-alpha and interleukins are key inflammatory signals produced by macrophages. They induce fever, loss of appetite, and lethargy, promote weight loss and cachexia, and increase endogenous corticosteroids. This table summarizes the pro-inflammatory mediators and their effects. From TNF-alpha to substance P, each mediator plays a specific role in orchestrating the inflammatory response. Acute inflammation can have several outcomes: complete resolution, healing by connective tissue leading to scar formation, or chronic persistent inflammation with extensive tissue damage. Chronic inflammation is characterized by its prolonged duration, lasting weeks to months without resolution. It can be triggered by persistent infections, hypersensitivity disorders, toxic exposures, and chronic diseases like atherosclerosis. Chronic inflammation differs from acute inflammation in several key aspects. It's characterized by the predominance of monocytes, lymphocytes, and macrophages, continuous cytokine secretion, repetitive tissue damage, delayed healing, and the replacement of injured cells with connective tissue. In chronic inflammation, T and B lymphocytes amplify and perpetuate inflammatory signals as seen in autoimmune disorders. Granuloma formation, where macrophages aggregate and transform into epithelioid cells, is a distinctive histologic pattern. Wound healing is a complex process with 4 distinct phases: hemostasis, inflammation, proliferation, and remodeling. Optimal healing involves the replacement of injured cells with cells of the same type, leaving no trace of residual injury. Hemostasis, the first stage of wound healing, begins shortly after injury. Exposed collagen surfaces attract platelets, which aggregate and secrete inflammatory mediators. Vasoactive amines cause short-term vasoconstriction. The inflammation phase of wound healing involves vasodilation, increased vascular permeability, and chemotaxis. These processes facilitate the delivery of immune cells and growth factors to the wound site. During the proliferation and granulation stage, granulation tissue forms, with fibroblasts playing a key role. These connective tissue cells synthesize collagen and provide the extracellular matrix for wound healing. Proliferation also involves angiogenesis, where vascular endothelial cells create new blood vessels. Granulation tissue secretes growth factors and cytokines, while epithelial cells migrate and proliferate to form a new surface. The remodeling stage, occurring about 3 weeks post-injury, involves the structural redefinition and reshaping of scar tissue. Fibroblasts and myofibroblasts are actively involved in this process. Wound healing can occur through primary, secondary, or tertiary intention. Primary intention involves simple reapproximation of edges, while secondary intention involves more complex tissue regeneration and scar tissue formation. Tertiary intention involves delayed closure to allow for drainage. Primary intention is the least complicated type of wound healing, characterized by clear edges, no missing tissue, and simple epithelialization. Granulation tissue is present by day 5, and by 1 month, connective tissue is covered by an intact epidermis. Secondary intention is more complex, involving extensive tissue loss and preventing regeneration of original cells. It requires granulation and fibrous tissue, causes more intense inflammation, and has a high susceptibility to infection. Tertiary intention involves missing deep tissue, contamination, and a period of cleaning and leaving the wound open before closure. It often requires packing, dressing changes, a wound drainage device, and may necessitate skin grafts. Wound integrity is compromised even after healing is complete. Wounds typically achieve about 70–80% of their original tensile strength after 3 months, requiring careful support and care. Eschar is dead tissue that sheds or falls off healthy skin, often seen in burns and pressure injuries. It requires debridement to remove necrotic tissue and promote epithelialization. Several factors affect wound healing, including nutrition, oxygenation, circulation, immune strength, contamination, mechanical factors, and age. Adequate nutrition, particularly protein intake, is crucial for optimal healing. Dysfunctional healing can lead to wound rupture, including wound dehiscence and evisceration. These complications require immediate protection with sterile, saline-moistened dressings and prompt medical attention. Complications of wound healing include keloids, contractures, dehiscence, evisceration, strictures, fistulas, and adhesions. Each complication presents unique challenges and requires specific management strategies. Subscribe, like, comment below, and share.